Medurstand, Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine. And today I'm going to talk about this relatively new development in the field of diabetes. And this is the availability of a 3-drug combo pill, and you can treat diabetes, most of the patients with type 2 diabetes, with just one combo pill. And this is quite an exciting development for both physicians as well as for patients. So the management of diabetes starts with the first 3 steps. First of all, of course, is to make a diagnosis, and you all know the criteria, and these are the given here. And then immediately after making the diagnosis, we start with the lifestyle changes, which basically means controlling diet, restricting total calories, restricting carbohydrates, and doing some exercise on a regular basis to manage your weight. And I have a separate video on this. And third is the addition of metformin. Before 2010, it was generally recommended that you try lifestyle changes for 3 months, and if patient is unable to achieve his goal of A1C given by ADA and EASD, and the goal was to get to 7 or less, then you consider metformin. But after 2010, we have realized that most patients, they are unable to carry on lifestyle changes or to maintain them, or they fail. So I think since metformin is a very cheap drug, so we use it along with lifestyle changes at the time of diagnosis. Unless somebody has got just borderline diabetes and he is very motivated and keen to try lifestyle changes, you could do that. You could just try lifestyle change. Otherwise, metformin is usually started at the time of diagnosis. So we're going to examine metformin in some more detail. It is incredibly cheap, incredibly effective, and incredibly safe. And I'm very sure about every word I used. Although there are some side effects, but generally it is very effective medicine. One of the oldest and still one of the most widely used drug in the field of diabetes. And it is of first choice unless patient has some contraindication, usually in the form of kidney disease, or patient has tried it earlier before coming to you and patient has not tolerated. Then we move on to the next agent. It is usually started with low dose, which is 500 milligram twice a day. I think that is the lowest I start with, and we can gradually escalate the dose to maximum of 3 grams. We can't exceed 3 grams. So optimum dose is perhaps 2 gram. When we compare the side effect profile and the benefit, around 2 gram is optimum, but we can push it up to 3 gram if patient is tolerating it well. Of course, we have to achieve our goal. If patient can achieve his goal of A1C of 7 or less at a smaller dose, then we don't have to increase it. But there are 2 problems. One is the GI upset. Approximately 25% of the patient, they would have some kind of GI upset. Some would have mild discomfort, other would have very severe pain and diarrhea and abdominal pain, and they will not be able to tolerate metformin. Generally, low dose causes less side effects, and if you increase it gradually, the patient can tolerate it better. But then there are patients who can't tolerate metformin in any form. Since it is a long-term plan, so I think there's no point in continuing with the medication which is giving troublesome side effect. And the second problem with metformin plain is that it is to be given 3 times a day. That makes it slightly cumbersome. But there is a solution. The solution is in the form of XR formulation. XR formulation is extended release formulation, and depending upon which technology has been used, metformin can work for 24 hours. So instead of 3 times a day, you will have to take it once a day. And this is what they have done in combo pill. And interestingly, with slow release formulation, the GI side effects, they reduce by 50%. Because medicine is released slowly, your stomach and intestine gets exposed to the medicine slowly, and low dose can be tolerated, so side effects profile becomes better. So I think this is very important development, and based on this I draw my first conclusion, and the first conclusion is that despite the availability of many other drugs, according to the ADA and EASD algorithm, metformin maintains its first position. Although there are many other drugs, they are contenders to be the first line, but to date, metformin remains the first line treatment because it is safe, it is cheap, it is effective, it has got weight benefits. That means it can help you to reduce some weight, or at least it will not increase the weight. And it has got very low risk of hypoglycemia because it does not stimulate beta cells, it does not increase your insulin level, and it has got very good cardiovascular safety record. In fact, it could actually give you some benefits as proven by UKPDS. So from every respect, metformin is rightfully the first line treatment of metformin of diabetes. So there are people who, despite the maximum tolerated or maximum recommended dose, are not at goal, and the goal is A1C of 7 or less. So in that case, we have to consider other medication. Other medication could be GLP-1 receptor agonists or SGLT2 inhibitors. These are generally expensive and are considered in those patients who have high risk of atherosclerotic cardiovascular disease or have incipient nephropathy or have some kind of heart problem, right? And for many sulfonylureas and TZDs can be considered, especially if the price is a major consideration. These drugs are relatively cheap and very effective glucose lowering therapy, but beyond glucose lowering therapy, they do not have much benefits, especially the sulfonylureas. I think third group is DPP-4 inhibitors based on certain criteria, which I'm going to explain in the next slide. My next choice would be DPP-4 inhibitor. Somebody who is not on goal with full dose of metformin, next rational choice would be DPP-4 inhibitors. Number one, they are very well tolerated. Side effect profile of DPP-4 inhibitor is just like placebo, so no side effects at all. And modest HbA1c lowering effect, which would be added to metformin, and glucose dependent effect on insulin secretion and glucose dependent effect on glucagon. So it would act only when glucose is elevated. So that would mean very low risk of hypoglycemia. So that adds to the advantages. So, but there is a problem. The problem is that most DPP-4 inhibitors are excreted through kidneys, and people with diabetes, they tend to develop kidney problem. So if somebody has reduced GFR, you will have to adjust the dosage of DPP-4 inhibitors according to the GFR, and your calculation may not prove very correct. So there may be some undesirable effects of DPP-4 inhibitor in the setting of CKD. So there is a good news that now we have a DPP-4 inhibitors which is not excreted to the kidneys. It is almost completely excreted through the liver and the biliary system. So irrespective of the fact that whether or not there is underlying kidney disease in diabetes, linagliptin is safe. Linagliptin safe dose 5 mg for everyone, irrespective of GFR, irrespective of CKD, irrespective of proteinuria. So linagliptin out of all DPP-4 stands out as best DPP-4 inhibitors because it is convenient, just 5 mg once a day, which is absolutely safe in the background of kidney disease. So I think after metformin, DPP4, and out of DPP4 inhibitors, I believe linagliptin is perhaps the best choice. So there is actually a wealth of data favoring linagliptin. I will not go into the details because then lecture will become very long. First study is Carmelina, where they studied cardiorenal outcome with linagliptin, and then Carolina, where they compared it with glimepiride. Then the trial Marlina type 2 diabetes, where they studied linagliptin in people with albuminuria, and then Linda trial, where they studied it in people with non-alcoholic fatty liver disease, which is almost a universal association of type 2 diabetes. Then they studied in enable in people with heart failure, and then Lina type 2 diabetes in elderly. And very interestingly, in all these situations, linagliptin fared very well. So that lead to the second conclusion, that linagliptin is a safe option in a wide range of patients with type 2 diabetes not controlled with metformin alone, because of its neutrality on atherosclerotic cardiovascular disease, no harmful effect on atherosclerotic cardiovascular disease, and beneficial effect on heart failure, CKD beneficial effect, or at least no bad effect, NAFLD no bad effect, elderly. So in all these situations, linagliptin is a good choice. Now, how about we have studied metformin with its merits, and then we have studied linagliptin with its merit. How about combining these two drugs in one single pill? They have complementary action. So whenever you combine two drugs for the same indication, they must have complementary action. If they work through the same channel, same pathway, there is absolutely no point in combining them. So let's see if they have complementary action. Metformin reduces hepatic glucose production, and it increases peripheral glucose utilization by reducing insulin resistance. So through these two mechanisms, metformin primarily works on fasting glucose. So it corrects your fasting hyperglycemia. Linagliptin, by inhibiting GLP-1 degradation through DPP4, and it leads to increase in insulin level and reduction in glucagon. Both will help to reduce glucose in postprandial phase. So I think both have complementary action. One works on the fasting, the other one works on the postprandial glucose. So both fasting and postprandial glucose will be controlled, and you will get very good average glucose and very good A1C. Complementary mechanism of action, we have proven this, and there's low risk of hypoglycemia and there's weight benefit. So both do not cause hypoglycemia even when combined. So I think very good reason to combine them. And in fact, it looks like as if this is an ideal couple made in the heavens. So very nice combination. So these two drugs can be combined in one pill. Many companies, in fact all gliptin, sitagliptin, vildagliptin, linagliptin, they come in combination with metformin, and they have various strengths available. So whichever is right for you, you would have low strength and then moderate and then high dose. Some dose once a day or twice a day will be suitable for your patient and should help to get the A1C to go. But what if this combination also does not bring your glucose to the ideal level? Then we have to move further. And out of three options, we have considered SGLT2, DPP4 inhibitors, and sulfonylureas. I think now I would consider SGLT2 because of certain benefits, certain unique advantages, which I'm going to show you right away. This is the mechanism, how it works. Normally the glucose in the blood is filtered into the nephrons, and almost all of it is reabsorbed here by an enzyme called SGLT2. 90% of it is absorbed by SGLT2, and further 10% is absorbed by SGLT1. So as a result, no glucose is excreted in the urine. That is a very, very beneficial mechanism. In fact, without this, life would not be possible, because we will end up in hypoglycemia hours after eating. So since in diabetes there is too much glucose in the plasma, and in fact in diabetes this mechanism is overactive because too much glucose is excreted. So kidneys have become over efficient in reabsorbing glucose and bringing it back to the blood. So some scientists thought that if we block this protein, if this enzyme, we might allow glucose to be excreted. That will of course help by controlling glucose level, but if you promote glycosuria, glucose level will come down. And there will also be some weight loss, because glucose is a nutrient. Once you're losing nutrient in the urine, that means you will lose some weight, especially if you're already trying to lose weight, which most type 2 diabetic patients should be doing that. And there is modest blood pressure lowering effect, because it contracts your extracellular compartment a bit, because it is called SGLT. Sodium and glucose both are excreted, and along with that some water goes, and there is some blood pressure lowering effect that might actually contribute towards the unique benefits of these SGLT2 inhibitors, which are beyond the benefits through glucose control. So there is low potential of hypoglycemia, although some people, they can get hypoglycemia if they have not eaten, but the chances are very low. And many beneficial effects through its pleiotropic effect, and these effects are over and above the benefits achieved through glucose control. And the effect on heart failure, the effect on CKD and atherosclerotic cardiovascular disease, in this lecture I will not be able to go into the detail, but science has proven that SGLT2 inhibitors, they reduce heart failure chances, hospitalization for heart failure, progression of kidney disease, all parameters, and then all the MACE 3 points are reduced. So it's a great drug. And these effects are independent of beta cells and alpha cells. Why it is important to mention it here? Because DPP4 inhibitors, they work through beta cell and alpha cell. So since the SGLT2 inhibitors, they use a different channel, the glucose lowering effect will be over and above that achieved by DPP4 inhibitor. And also independent of liver. So the effect achieved by SGLT2 inhibitor will be over and above achieved by the metformin through liver. So that means that SGLT2 has got complementary action independent of beta cell, alpha cell and liver. So the effect will be over and above the effect of DPP4 and metformin. So there is a wealth of data favoring empagliflozin, and again I will not go into the detail, I will just mention them. EMPA-REG outcome trial, which proved, this was a CVOT trial which proved that empagliflozin not only is safe from cardiovascular point of view, it actually extends benefits over and above, more than placebo. And EMPA kidney means that people with albuminuria, people with reduced GFR, they improve, their kidney functions are maintained for longer. EMPRE reduced, people with heart failure and reduced ejection fraction, they get benefit, and people with heart failure and preserved ejection fraction, they get benefit. In fact, this is very interesting because before this, there were no medicine which would work on the heart failure with preserved ejection fraction. and EMPA heart, and then East type 1 diabetes, and when empagliflozin was added to insulin. So in all these trials, empagliflozin demonstrated very convincing benefits. So that leads to the conclusion number 3. The third conclusion is empagliflozin is a very attractive option for people with type 2 diabetes, particularly with high risk of atherosclerotic cardiovascular disease, heart failure, and CKD, and those who are not at goal. Even people without these risk factors can be considered for empagliflozin as a third line agent. So these are the benefits: heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, CKD, kidney function preservation, and protection on atherosclerotic cardiovascular disease, over and above good glucose lowering effect without weight gain, without hypoglycemia. So that makes it a very, very attractive option. Now let's examine if the metformin and empagliflozin, they can be combined and they have complementary action or not. Metformin reduces hepatic glucose production and promotes peripheral glucose utilization. Empagliflozin promotes glucose excretion through the kidneys. So there is complementary mechanism of action, and there's low risk of hypoglycemia, and there may be some weight benefits. And again, it looks like this is another ideal couple. Based on this principle, many fixed drug combination of metformin and dapagliflozin, various doses, empagliflozin, various doses, ertigliflozin, various doses, and other gliflozin which are not available in our country. So various doses are available. Various doses of metformin with various doses of this fixed drug combination are available. So patient can conveniently use this combination also. So first we examined combination of metformin with DPP-4 inhibitors, and now we can discuss the combination of metformin with gliflozin, SGLT2 inhibitors. There may be patients who are still not at goal with two drug combo. So we have used metformin with DPP-4 as a single drug, and we have used SGLT2 with metformin as a single drug. And how about combining all three? Since all three have complementary mechanism of action, so how about combining all three? How about going a step further and combining all three? Some brilliant scientists, they have done it, tried it, and came up with very nice results. So they have a rationale of triple drug combination is complementary mechanism of action, and then enhanced glycemic control, then cardiorenal protection and weight loss, then low potential of hypoglycemia and weight loss. The complementary mechanism of action is highlighted in this picture. The DPP-4, this metformin, it works through. This is the DPP-4 inhibitors. DPP-4 inhibitors, they work through increasing insulin and reducing glucagon, and SGLT2 inhibitors, they work through kidneys by excreting glucose, and metformin works through the liver by reducing hepatic glucose production and increasing peripheral glucose utilization. So I think there is very, very good sense to combine all three. It's a very compelling reason to combine all these three drugs in one pill. So data favoring a triple combination, metformin, linagliptin, empagliflozin, these are the trials, and they have shown that when all three drugs are used as separate pills in one patient, their effects are complemented and their side effects are not added, because their mechanism of action and their side effect profile is different. But they have done bioequivalence studies also. Before FDA approval, they want bioequivalence study, And when they studied these three drugs in one pill, and it was proven that three drugs, they work just like they would work when they are given separately. But in one pill, that would improve compliance, that would improve convenience and adherence. So on the basis of this, FDA has approved this drug. So the conclusion number 4 is a 3-drug combo of metformin, linagliptin, empagliflozin is a rational option for those who are not controlled with any 2-drug combination, those who are not at a goal of 7 or less. And to date, only this 3-drug combo is approved by FDA because of complementary mechanism of action, weight benefit, low risk of hypoglycemia, and cardiovascular and renal benefits. So on these bases, this 3-drug combo is now approved by FDA. US FDA approves triple combination tablet for type 2 diabetes, and these 3 drugs, these are ones which are combined, and the company have provided 4 different strengths. In all, metformin is 1000, but linagliptin could be 2.5 or 5, or empagliflozin could be 5, 10 or 12.5, and I'm sure in your patient one of this combination will be right. One pill just once a day, or maybe 2 pills once a day, or maybe 1 pill twice a day, so that easy. You can control most patients with type 2 diabetes. So power of triple combo, this is like a summary. 3 drugs, metformin, empagliflozin, linagliptin, all have glucose lowering effect and all have collective effect on very robust effect on HbA1c up to 2 to 3% lowering. And used together, they also have a good effect on weight. Metformin and empagliflozin would lower your weight, and linagliptin will be neutral. And cardiorenal benefits, all drugs, they have cardiorenal benefits. Metformin by controlling glucose, and empagliflozin and linagliptin by controlling glucose, and empagliflozin by also direct effect. Now remember, metformin is not a nephrotoxic drug. This I want to clarify, because once somebody develops significant knee disease, metformin is usually reduced in dosage and then discontinued. That is not because it is nephrotoxic, it is because metformin is excreted through the kidneys only, so there is a risk of drug accumulation, and then high level of metformin can become toxic for body, for liver especially. So that is why metformin is withdrawn once somebody develops significant kidney disease, reduced GFR like below 30, but that does not mean that metformin is a nephrotoxic drug. A trio can do wonders like this one. So triple drug combination pill can also do a wonder like this one. Now let's first, very briefly discuss pros and cons of combo pills. The pros I have already highlighted: very convenient, better compliance, better glycemic control, better outcomes. So that are the pros. And cons, I think one is less flexibility in individual drug dose titration. And the solution is this 3-drug combo pill is available in 4 different strengths. So I think out of 4, 1 would be suitable for you, at least for majority. And then if you're taking 3-drug combo, it might not be easy to figure out which side effect is caused by which drug. I think this is also easy because linagliptin, we know, hardly causes any side effect. Metformin is known to cause its GIT related side effects, so we can easily figure out it's metformin if somebody has GIT problem. And empagliflozin causes urinary related symptoms and complications, so we can again figure out. So I think I don't see any problem. I don't see a big con in using this triple drug combo. So what is the place of 3-drug combo pill in the real world? I think as a 3rd line drug, when somebody is not at goal with any tool, it definitely has a clear place. And as a second line also, if somebody is not controlled on one drug, it has got a place in the second line also, because then you will be using 3 drugs working through different mechanisms for better glycemic control with less side effect profile. And I would honestly consider it as a first line also in some cases. For example, somebody who is obese, somebody who already has some proteinuria, somebody who's been hypertensive and already has got diastolic dysfunction, so he qualifies for SGLT2 inhibitor at the time of diagnosis, so his treatment can be started with 3 drug combo. So if the 3 drug combo is also not effective, then of course we have to move on. You know, diabetes is a dynamic disease. With the time we have to go to the next step, and of course if 3 drug combo is not working, or 3 drug given separately is not working, there is no point in adding 4th or 5th drug, although there are some available, but the next best step would be, as recommended by ADA and ESD, to move on to add basal insulin. So basal insulin would be the best next step, but of course we will have to move on. So that leads to 3 take-home messages, 3 conclusions. One is a 3 drug combo of metformin, linagliptin and empagliflozin is a good option as 3rd line or 2nd line or even 1st line therapy for type 2 diabetic patient. The second conclusion is, if somebody is not at goal with 3 drug combo, instead of pushing further with oral medication, move to injectable. I think glargine can be considered. And then of course glargine is a basal insulin. With the time you would have to probably use multi-dose insulin. You have to intensify insulin. Patient would have to take combination or 3 or 4 doses of insulin a day. With that, I like to conclude, and I'm introduce my channel again here. This is my channel Medurstand, where all lectures are available. You just scan this QR code or write this word on the YouTube app or just anywhere in the internet. You will be right here in my channel. Thank you for your watching this video, and I really look forward to see you in my next one. Professor Aziz Rehman for Medurstand-Understanding Medicine.